Okay, welcome everyone to another pain podcast with hosts. I'm Tim Beames and I've got Bart Van Bookham with me. And
Hello.
This is the Painful Truths, where we're gonna talk about current debates relating to pain, and we're gonna give our opinions about that. And if you haven't heard it already, the last one we talked about was the statement "can't go wrong getting strong." So we had a great chat about that last time.
Did we had any response? Was there any response to that, Timmy?
There was a couple of responses, weren't there? There was a couple of disgruntled people, and then a few people that found that it was a nice balanced opinion. So yeah. So today we are going to discuss whether surgery for pain is a panacea or a placebo. So a panacea, it's a cure-all, or is it a placebo? Is it exerting its effects through other means than the ones that we assume are taking place from surgery, the cutting, the chopping out, etc. So that's what, and this comes from Elon Musk telling everybody that if you've got neck pain, then go and get your disc removed. Go and get a disc replacement. First thoughts. I mean, let's visit that statement first of all. What are you thinking hearing that from Elon Musk?
Just for the record, did he had a disc replacement himself?
I think he did. But
wow.
And I think, I mean, look, I don't know how he runs his life, but from what I read, and it was effective as well. So that's awesome, great.
Yeah. Well, I wouldn't preferably have surgery on my body in the first place, but it's an interesting statement, and I can see him where his you just following his timeline on X, for example, it really resonates with his group, I guess. This is just how he thinks. This is just his world, and if something's damaged, fix it. And if you need something, buy it. If you want to get rid of something, just fire the whole department. And well, we can say he's been quite successful though, in a way.
I mean, he is, isn't he? Is he the richest person that's ever lived, or something like that?
Might be.
If you measure success in terms of your earning, then certainly he's been extremely successful. So.
Yeah, so I understand where this comes from, and I see patients who have had surgery and gone through a very positive experience. They would be likely to be how you say that? They're basically going to promote it to their, and just on that side, it's when people like friended people going through a successful treatment, they are likely to support and help you to advertise. Even if it's going through a chronic pain state and they do much better, they tend to be like supporters for the therapist. I think that's a very common thing. If you want to build your practice, you're relying on people's experience, and they will buy. So like the word of mouth is very strong. But today in social media, it obviously has massive impact and big responsibilities, and that's where we should stay for a while and have a think of, is that really what he's trying to say? So
totally. Yeah. I wonder whether I can just come in with a slightly balanced thought, because the conversation that we're having is relating to going for surgery for pain, and perhaps we need, even within that, to have a caveat, because someone can have pain and then they can have really quite serious problems related, as a part of that as well. So the tissue's lost viability, for instance, or they've completely lost function of muscle or things like the bladder or bowel, and that surgery is wonderful and absolutely warranted for something really quite serious like that. But if there aren't those signs, then and that's really, I think, the discussion that we're having here is that if someone's had an ongoing pain state, should they go for surgery? I just want to put a few sort of scenarios out there, because I treat a number of people who have complex regional pain syndrome, and that can develop after relatively simple, fairly minor occurrences. So things like a sprained ankle. I've had a couple of people who've had surgery following a sprained ankle to the lateral ligaments of the ankle. I've had a couple of people who've developed CRPS after fairly simple surgeries of the knee, of the wrist. So there is a risk of going for surgery and then developing something that, CRPS can be a horrendous condition for someone to experience. But equally, I've had a number of people who have had a pain problem, and typically they've gone with a fantastic mindset, worked really hard pre-operatively, and got themselves in a great place. And surgery was a wonderful thing for them as well. So
it is. You
do see those the sort of the diametric opposites, don't you?
Exactly. So that's where the nuances lie, and I think a summary. Generally, the science basically suggests that surgery for pain is not great, but surgery for neurological problems can be great. And that's where the nuances lie. I think when you get surgery, and that you won't get surgery for pain as the primer, if that's the primer problem. If you have a neurological problem that creates neurological issues, which is not pain, obviously there could be loss of strength, sensibility, or sensitivity in the skin, for example, or any neurological related problems that have a risk. Surgery can be massively important, but not for pain. And I think that's something where a surgeon, like a surgeon, would consider his treatment to be successful, is if the neurological problem is solved, not if the pain is gone. Because they always tell you, if you're asking, so please, if you're asking the doctor whether does my pain go away after the surgery, they always say like 50-50 or like 80%. They will never say 100%. Would this surgical procedure be successful to get rid of this herniated disc? Yes, 100%. Is this procedure safe? 100%. Will I get rid of my pain? I don't know. I'm not gonna tell you that it's gonna, because you gotta sue me if it's not, right? Because that is exactly what these surgeons are doing. They're doing a great job in doing a very sophisticated procedure that is very helpful to change this anatomical issue that has occurred in the human body, which and we have to be very humble for that, right? So over the like I said, I think the procedures, and even for all types of procedures, have been life changing, and but it's definitely not the panacea for pain. It might be for, let's say, herniated disc that are, or fractured limbs and so on. That would be, I would definitely go for surgery, but I'm not sure if it's just pain. I wouldn't.
I've as you're saying that, I remember. Do you remember Tiger Woods had like ongoing back pain, and he had several surgeries, and there was a point when I remember reading like all the different headlines saying Tiger Woods has had third or fourth surgery. I can't remember now how many it was, but this surgery is a success, and it was like the day after the surgery, and you're like, well, what measure of success? And so it's lovely. Like,
it didn't kill him.
Yeah, yeah. If the measure of success was you took the bit of discount that you wanted to take out, then
Yeah,
absolutely you were successful. But and not killing them. I mean, if you go back to the mid 1800s, the late 1800s, and you read some of those surgical papers, they're brilliant because they go, oh well, yeah, a couple of people died, but forget about them because let's look at the people who who survived and how well they did. So,
but
so success from surgery, depending on who you are, means very different things. And I had this yesterday. Actually, is one of my patients said to me, the surgeon told me that under anaesthetic, my leg moved really, really well. And it's like, yes, you weren't away. There wasn't any sort of conscious or unconscious ability to be able to effect change of your own movement. So yeah, you often get those reports back, don't you?
yeah, totally, and it makes sense, right? And I think from the perspective of, let's say, plausibility, it has, from a mechanistic view, it makes all sense of the world. If you're gonna get rid of it, if you take it out, it must be gone, right? Though even the most common procedures that are being done for mainly for pain, like osteoarthritis in the knee, like total hip and knee replacements, can be very successful. But in almost 30%, people will have ongoing pain after surgery. Would be fair, so they don't. So they will have a successful procedure, and they might be able to do more, but they're still in pain, which is still
Yeah,
successful in terms of being able to progress in life or being able to be active. If in some degree, if people have very strong inflammatory joints, it can be massively important to have this procedure, which is obviously is successful. But if it's just for pain and the joints seem to be okay,
mm.
then it won't be the right decision. There are probably much better options for treatment, um, instead
I'm
of
going to
going surgery.
put it out there because it could be the right thing, but not for the reasons that you think it is.
Exactly. Yeah.
Because let's say that there you have this ongoing, let's call it like a low grade inflammatory response in the body, some sort of neuroinflammation that we think might be a part of a contribution to an ongoing pain state, then having surgery might sort of be that shift that's needed for the immune system to go through its full cycle and it essentially issue some signals to say, okay, it's time to stop. So someone could have surgery, and actually, it might have a really wonderful effect on the possible immune and inflammatory contributions of that
Mm,
pain state.
totally. Yeah. And it's interesting because it's such a big procedure, right? There's happening a lot, which is not solely like cutting some skin and getting amputating a joint and replacing it. Interestingly, there's so much happening, and also in the neuroimmune. So you can have a debate on every kind of, even even on the more recently, like how consciousness responds, how predictive processing fits in the notion of surgery. It's really interesting to think about it like that. If a patient asks me, well, should I do this surgery, and I will always say depends, and let's see the data, what we've got, what are the pros and cons, not just for the surgery, but also on what is the likelihood that if pain is the most primary, or their most biggest issue they have in their health at that stage, in experiencing their life, which is, I wouldn't recommend it just because it's a bad joint. It would be more than that. So I think there's a role for a clinician, to put this all together and making this like a shared decision. Because I think the surgeon would be biased in a way, because he would or she would be happy to do surgery if they can get it done and safe. and it may have some benefit. But I think a clinician in general could be like there's slightly less bias because we don't earn money from this surgery, so we can have like, let's put it all together. That's what we've got, and it would be a nice way of. I've had multiple cases where people changed their mind, and some of them actually did do surgery, and they thought they shouldn't do it, and the other way around. So it's not always like you should tell people shouldn't go for surgery, because that's not what the message should be, I guess.
No, I think I absolutely agree with you. If someone, it's the underlying problem is ongoing pain, it's not my decision to make as their clinician, but I see it as my job to help, best inform them about what's going on and prepare if they do go for the surgery as well.
Yeah, exactly.
Or at least go for surgical opinion, prepare them for that.
Yeah.
There's you mentioned about knee replacements and hip replacements, and I remember hearing many years ago the idea from I believe he's a physio, but Anton Harms. Do you come across Anton in Australia?
I'm not sure.
He was one of Dave's friends, and he had this idea of phantom knee pain following total knee replacement, and this was years and years ago. But yeah, so it makes you think. Then, okay, many people have heard of phantom limb pain when you've taken a part of the body away, but it's true if you replace a part of the body as well, and you're left with pain. What are the mechanisms in play then that mean that you are still in pain? And it surely that should force some people to totally, challenge their thinking about what pain is then. You've got to hear this. I've got. I was having a discussion with a patient the other day who saw a pain specialist. I won't say where this happened, but the pain specialist said to them, there are three reasons why you'll be in pain. It's either your joint, your disc, or your muscle, and we're going to inject each one in turn and see which it is.
Wow.
And then I'm thinking, it's difficult not to be frustrated hearing things like that, isn't it? And to consider that person is trading as a specialist in pain baffles me, actually. But it does demonstrate that there are still people there in a position where they're treating someone, many people in pain, and the models, their understanding of pain that they are using are completely outdated. And so people are going to come across you. If you are listening to this and you're a clinician, you are inevitably going to be confronted with people with different thoughts and about pain.
Yeah, absolutely. And hey, there's no. I think there's a part of communication, and this where the underlying theoretical and like ethical considerations of this. Also, want to highlight. So we're planning a session in the future, probably somewhere in November, about why we know all this stuff, but we don't bring it to the patient. So in general, will be like a biopsychosocial approach. Why is it so hard? What's the boundary? What's that burden that the clinicians can't bring it? Because when we go to IASP, for example, we'll be around in Amsterdam, obviously, in August. There will be like 6,000 clinicians and nurses and therapists, and they all know about it's important, but only a small percentage is actually doing it. I would say like practicing biopsychosocial health. Instead of that, they sort of packaging it in what they think is important. One of the reasons, like we're going to do it, we're not going to talk about the psychosocial part because patients don't want to hear it, which is bollocks. It's not true. So there seemed to be a burden of, because it makes it anatomically implausible that if you do this, it's like it's the muscle, it's the joint, or it's the what was it again? Like the ligament
It was the disc.
or
Yeah,
the
the
disc.
disc.
Then you know, because it makes sense, right? It sounds really plausible. It's easy to sell. And if this doesn't work, I can't help you. Or it's probably in the brain, and just go to that therapist. And that is,
Yeah, well,
it's
that's
very, yeah,
that, that's exactly it. Like, what happens if those injections don't help? Like, then what? You know, instead of waiting until the and then what? Why not just be much more professional and knowledgeable now? Like, do the right thing immediately.
it's
And if the right
dualistic. Yeah.
and if the right thing is working in a holistic way and engaging with psychological therapies at the same time, then that should be how we do it.
And it will be like it has a very understandable background, because the let's say Descartes, in the very beginning when they started to split this, it was basically body and mind, but the mind was representing God. So if it's not in the body, it's in the mind, and therefore it's God. You must have done something terribly wrong in your life. You're fucked. So therefore it must be in the brain. So the brain is basically the new God, and therefore it's been affected by this. So it's really interesting if this dualistic thinking really brings it back to something. So when it's in the brain, you can't treat it, right? Because it's something that has happened to us. We now know better, but it's very hard to believe that certain behavior or thoughts and beliefs and emotions can drive these systems that makes us become, let's say, super pain sensitive, hypersensitive, whatever you want to call it. And interestingly, that's still the paradigm that's still there. If it's not in the body, it's in the brain. The brain doesn't sound, it may sound like less, it may sound biased or psychosocial, but it's actually still very much in the open air. It's not, nobody really knows what's going on, and then we're trying to retrain the brain. I'm not sure what that means, but it basically comes down to cognitive behavioral therapy. It comes down to emotion regulation, which is all great, but I think the way it's been presented, either go to the doctor, and if he can't find it, it's in the brain. So this is where surgery, if surgery doesn't work, it must be in the brain, which is terrible to hear, because it puts you in a position, or I guess it's even putting the patient in a position where you think, oh, I've done wrong, right? So I must have done something terribly wrong. I could have prevented this. It's all in the head, which is it only, I think, in that sense, in this dualistic surgical paradigm, it's very likely that we're not helping patients at all. We're making them worse in presenting it like that. And I think surgery should be part of the treatment possibilities at some point, but it never should be the first thing to do or the last thing to do. It's part of the palette. I say it's part of the range of the variation of options that people have. And if we do have good evidence that this could be the right thing to do, nobody's going to stop you. We're living in a Western world, and basically everyone can get surgery if needed. And this obviously doesn't go for, let's say, non-Western countries, where it's actually people who need surgery can't get surgery. So that's the other side of the story, which is horrific. Anyway, yeah.
Yeah, totally. See, what you're saying is there's a balanced opinion out there.
Oh.
I'm wondering, like, because then you bring up the, like, if you want the brain body link, and I mean, I'm not sure that there could ever be one without the other, but you could also see where having surgery and the change that occurs within your body might affect you from an emotional point of view as well. I mean, for instance, we know people they don't feel like the life and soul of the party after surgery, do they? And that's not just because you're on pain meds, but is that there is a literal shift in your emotional state with what's going
Yeah.
on in your body,
Mm.
and vice versa as well. And I'm thinking about God, all the time I spent like learning about neuroscience and things. But there were theories around. I remember there being. I think it was Irvin Core who came up with the idea of denervation supersensitivity, where there was it's a bit like double crush, where
Mm.
you had changes in one part of the nervous system that then meant that you were more susceptible to developing changes in another part of the system as a way of rationalizing why someone could have surgery and yet they could still develop problems and changes of those tissues or of surrounding tissues or even of tissues on the contralateral side of the body, so the same tissues on the opposite side of the body.
Mm.
And that was more quite sort of locally theorized that there was something happening within the nervous system that might have changed that. But now we could theorize that actually, why separate it into nervous system? It's the person. It's the person, and whatever it is that's going on in that person, why it's localized to that specific point is another matter, or why exactly or how exactly that changes following surgery is I think that there's still a huge amount to learn, huge amount to find out.
Yeah. Well, there's also, like, just back to surgery. There's lots of surgery that has been poorly investigated. So the research is not really compelling because it seems to be quite like high bias rates. It doesn't seem to. So just from the other side, where we were trying to push for like biopsychosocial health and education, it seems that we constantly have to push for like the highest and the best evidence possible, and creating incredibly sophisticated trials that are trying to prove or prove wrong, if you like, compared to the surgical procedures and their research is like, why is the number of double-blinded placebo trials is so limited? And once they've done these double-blinded placebo trials, actually it comes out that the surgical procedure was not as good as they thought. And that's consistently. And I think just a shout out to Ian Harris, like the surgery, the greatest placebo, which is a book you definitely should have a read on, because it gives you a nice view on and an overview on what's happened over the ages, like crazy procedures that actually more people died from it than there were surviving it and were helping them. But it sounded plausible, and that's why they done it so long. And even today, there's so much procedures that's still there where we know of it are actually not great, or actually very poor and a waste of money to do it on that extent and that amount of people. So, so again, so have a shout out. It's just a shout out to Ian Harris and his work and his research group. In Sydney, I believe, is still doing, probably is the biggest research group on placebo surgery, which is and that's not like, it's not a massive field, but what they do is great, like high quality research with good methodology to see if this procedure really works. And so far, what they've been done every single paper they published was like getting to news headlines, uh, because it was like, oh my god, this knee surgery wasn't as good as we thought. Oh, we shouldn't do these disc replacements actually because nobody is really getting better. Yeah, that's it really changed my view on surgery, because I wasn't that interested in surgery in general because it wasn't my field. But now I do. Now we see there are so many things that are flawed, but also we can actually improve there, and we do need to collaborate. It's there's still like a great place for surgery, and just use it where it's where it should, and where it should have an effect in a positive way. Yeah. What is your have you?
Unfortunately,
Yeah, we have
we're
to.
running out
Oh
of time, aren't we?
no way!
Should we? Yeah, and I was starting to think, oh, we could talk about lobotomies and leucotomies and rhizotomies
Ah,
and all the different things. Well, you had to learn all these long words, didn't you, and figure them out. And but
yes.
you can imagine, like all of those surgical procedures that were designed, for, to be able to change pain
Yeah,
yeah,
exactly.
wow,
Yeah. Yeah, we're gonna have a on the 3rd of July 2024, if you we're gonna have a session with Andrea Evers. She's a professor in the University of Leiden, which is in the Netherlands, and she's a leader in the field on placebo control trials, and she's a psychologist by background, but she's done amazing work, and she's gonna tell us about her work. So that will be a science sessions on the 3rd of July. So that's something to remember to sign in. You probably find more on our website about this session very soon. So, and I think the title is like how placebo can actually improve your outcomes, which should sound great, right? Why not? So that's going to be a great session. I'm pretty sure about that.
so it's not a dirty word.
It shouldn't.
And I suppose in summarising the session, we started with surgery for pain, panacea, or placebo, and I guess we're not taking the sexiest route, are we? We're somewhere in the middle. There are merits for both, and it'd be brilliant to listen to Andrea and hear her thoughts around placebo as well. But we've I think the balanced opinion I'm getting from what we were talking about is that there are absolutely times when surgery is indicated. If it's for ongoing pain and you can set the process up in the right way, who are we to say? We clinicians are not the ones making that decision, but we can certainly help to inform people better about what they're going to go through. And also we can help them with both the preparation and the recovery as well. But what exactly is going on when they have surgery? For pain, that is. Who knows? Now, if you're listening in, thanks so much, first of all. We really value people sitting in. And I was speaking to someone yesterday and they were saying, oh, we've been listening to your last episode and loved it. And thank you so much. If you do enjoy it, share it, tell everybody about it. Your neighbour, your butcher, taxi driver, whatever it is, and subscribe to the channel. And if you want to get really confident treating pain and all the presentations of pain, then come over to the pub. There's some free guides that you can download. We produce material all the time summarising the work on our social media, so connect there. And if you really want a deeper dive, then there is a premium membership that helps all levels of clinicians. You don't have to be a pain geek to come in. All levels of clinicians get more confident treating people with pain. So check out our website for that.
Cool.
Bart,
that's a wrap.
Thanks so much for that.
Yeah, lovely. It was good fun. Yeah, we're already pondering on the next episode. Yeah, we will find out. Yeah, absolutely. Thanks, mate. And thanks, guys, for listening and we're watching. Bye bye.